Good morning, everyone. Welcome to this morning's informational briefing. It is Friday, March 6th, 10 a.m. in room 329 in our beautiful state capitol. As all of you know, this is a joint informational briefing on behalf of the House Committee on Health. I'm Greg Takayama, and on behalf of my Senate colleague, Senator Joy Senventura, who is chair of the Senate Health and Human Services Committee, I'd like to welcome all of you and thank you for being here. First of all, I'd like to open with a bit of sad news. We just learned this morning that our former colleague in the legislature and former Congresswoman Colleen Hanabusa has passed away. So this is certainly sudden and unexpected and sad for all of us. So I'd like us to observe a moment of silence, if you would. Anyway, thank you very much. I'm sure she'll be very much missed by all of us. Anyway, I'm gonna keep my introduction brief. This, as all of you know, is a informational briefing on the Rural Health Transformation Grant. One of the few actually beautiful things about the Big Beautiful Bill is that it provided funds nationally for this program, and here in Hawaii, we submitted an application which was apparently well received because we received almost $200 million for each of the next 5 years, $1 billion, and that stacks up well, if not the best, of any state of our comparable size. So congratulations to the governor's office and all of you for your work on the application. What we applied for and what we got, we're about to hear from all of you. So let me turn it over now to Lauren Kim.
Good morning, Chair Takayama, Chair Sanbourg-Ventura, members of the House and Senate committees. My name is Lauren Kim. I am the Chief of the Office of Planning, Policy, and Program Development, Legislative Coordinator, and as always, a proud resident of House District 34. I'm here representing the Office of the Governor. The reason for that is the artifacts of project administration for RHTP, or the Rural Health Transformation Program, are being run through the Department of Health. So the Governor has not stood up his dedicated RHTP team. My proximity to the documents such as the special project and the position descriptions affords me a little more insight than some of my other colleagues into the way the Governor's office is setting this up. I'd also like to ask Mr. Ian Withy-Berry to introduce himself.
Hello, I'm Ian Withy-Berry, a policy assistant in the Office of the Governor, helping out, supporting Lauren, and here to answer any questions. Thanks.
And so Ian will chime in as when he thinks appropriate. So very quick background, RHTP program was announced in June 2025. The state of Hawaii received $188,892,439.75. I am required by federal law to give you the specific and exact amount. In short, our goal is to expend all of that in budget period 1, including the 75 cents that I have here. So some lucky program is going to be able to buy chopsticks on Silent Longs with that money. So we're looking forward to that. Thank you, Chair, for mentioning that we do have America's only sitting physician governor, and Governor Green was the architect of the state's response. Being a physician, living and practicing in a rural area was a clear advantage for the state of Hawaii. Our physician governor architect identified 8 initial initiatives and farmed them out to agency leads who whittled that down and combined them into 6 proposals, including an oversight team for the office of the governor. At that point, when all proposals were collected and vetted, Governor Green sort of became the quarterback for the RHTP, making the final decision on what would be sent to CMS. And on December 29th, our award of $188,000,000.75 was awarded. For perspective, as Chair Takayama mentioned, the state of Illinois, with a population of 12 million, just got about $5 million more dollars than we did. So in our state of 1.4 million, this is going to go a very, very long way. So what's the takeaway? Well, being a physician governor during periods of healthcare transformation is good work if you can find it. So recommendation if you ever need to think about that in the future. I would like to, before we get into some of the detailed implementations, before I turn it over to the initiative leads, we are celebrating this large amount of money, this windfall to the state of Hawaii. But we also need to remember at what cost that this windfall fell in our laps. And that's because the One Big Beautiful Bill really eviscerated the long-term funding for Medicaid expansion. And going back a little bit more on the Wayback Machine, if we circa 2013 with the Patient Protection and Affordable Care Act, also known as Obamacare, funded Medicaid expansion to the tune of 90-10. So states produce 10 cents, feds kick in up to 90 cents to expand Medicaid roles for economically disadvantaged and rural residents across the United States. It was a game changer for many people who could go to the doctor for the first time, get a cavity filled, get a prescription filled without a $75 copay. So we do celebrate this windfall, but we still need to think through, as a public policy priority, what happens after 5 years. And so the emphasis for RHTP and the Office of the Governor will be on transformation, right? Just a little more background before I turn it over to my colleagues. This is a cooperative agreement, that is a type of federal program where the funding agency has substantial involvement. There are other kinds of grants where and I'm being glib here, here's the money, give us some good ideas, tell us what happens at the end of it. No, CMS is heavily involved in this. And part of the reason we don't have slides is because CMS is still debating and thinking through their communication protocols. So we are playing it conservatively. We do not want to get ahead of any CMS announcements while they're standing up their administrative infrastructure. We want to be the model state, do everything right, do everything well, and get the fullest amount of funds that we can get in the out years. We have met the project officers. The lead project officer is a lieutenant commander with the Uniformed Public Health Services, and the backup is a career civil servant with HST-HHS. Budget period one's priority projects for funding were solicited from a variety of sources, including the governor's RHTP website, agency priorities that were in line with the governor's priorities, and reaching out to trusted community partners. Although our overall application was approved, CMS needs to approve every line item going forward. How much of it is a formality versus actual scrutiny remains to be seen. It's probably somewhere in the middle. This is a significant amount of funds after all, so we understand the need for fiscal stewardship. There will be a significant amount of reporting, not just on the money, but details on contracts and outcomes, and again, that's to be expected. We anticipate good news on our line item approvals, but we still do not have anything in writing, so again, we are here to share what has already been publicly shared since that already received CMS approval. That being said, we anticipate a green light for whatever they approve, but prior to that, all state agencies involved in this are poised to execute or near poised to execute contract modifications, requests for information, requests for proposals. So when we get the green light and the state accounting and financing systems are set up, we'll hit the ground running. We will not spend 4 to 6 weeks writing RFIs. They're already being prepared, and so we're just waiting to pull the trigger. And I've just got two large points before my time is up. One emphasis on the implementation strategy being deliberated by the governor's team. It's about transformation. You're going to hear a few initiatives, specific initiatives, especially with Dr. Jack Lewin, that will have transformational benefits after 5 years that have to do with electronic medical records and value-based payment, as well as leveraging the AHEAD grant, which is more about global hospital budgeting. So, transformation is the sustainability plan, and so our community needs to think through what transformation means. It could mean an emphasis on community-based health, improving knowledge, attitudes, and behaviors, helping communities be healthier through needs assessments, giving them some tools that they can sort of take more control over their community's health destinies. And really, we all are interested in decompressing the acute care system and assuring as much care happens in outpatient before it escalates and in communities where people live 99% of their lives. So although there are specific proposals, We had about 5 weeks to turn around a complete application and turn it in. So as I mentioned, state agencies looked internally to invest in our own high-quality evidence-based work, so we funded ourselves. We reached out to partners who are reliable, who do good work. A lot of those funds scale existing programs. They're not necessarily transformative. And that's not a criticism. This is what all 49 other jurisdictions did. Who's reliable, who does good work, who's trusted in the community, do more of that good work. So what's critical when I talk about transformation is adjusting future budget years to maybe support less scaling and more true innovation and transformation. Again, the 10 or 15 years of Medicaid expansion money is unlikely to be there. So where are we going to be, and what is the legacy of the Rural Health Transformation Project going to really mean for our communities? And one last component is evaluation. So compliance with CMS is absolutely critical, but this project is a healthcare continuous quality improvement intervention. And so we need a hypothesis, a baseline, and a rigorous evaluation, process measures, outcome measures. You know, some of you may recall the Beacon Community Grant, which is a first attempt to tie high-tech health information technology, not with process measures, but with outcomes like A1Cs under control. Community probably quite wasn't ready for that much of a change, but we are in a much better position, as some of the other speakers are going to tell you about. And so, in summary, you know, 188 million ... and 75 cents. We're going to spend every penny of that, including those 3/4. And we really need to think hard about what transformation means. I think we all, this committee in particular has come to the conclusion, like those of us who do this for a living, that we have a sick care system. And this is a real opportunity to think through what a healthcare system looks like. So Ian, any comments?
I don't believe so.
Okay, so with that, I'll turn it over to the first speaker, which I believe is Dr. Buenconsejo-Lum, to talk about the Home Run program.
Okay, members, I'm going to ask the presenters to go through all their presentations to make sure we can have time to hear all of them, because we have a stoppage time of 11 a.m. So please proceed.
Good morning, chairs, vice chairs, committee members. I'm Buenconsejo-Lum. I'm the Associate Dean for Academic Affairs at JABSOM. And I'm joined by our Associate Director for our Area Health Education Center, Erica Davis, and also Claudine Chan-Nawuse, who is our Project Associate. So Home Run is our overall workforce development initiatives. There's actually many sub-initiatives. And as Lauren mentioned, some expand what we do, some in fact are new, and all with the goal of community at the core, and really helping make sure that the community is able to identify some of their priorities and needs. So I'm going to turn it over to Erica.
Aloha and good morning. So again, the Home Run is pipeline to practice. So I'm going to talk about some of the pipeline initiatives with these grant funds. At least one healthcare certificate training program is going to be implemented and available in all rural schools with a connection to a local industry partner. We will also be supporting HOSA Future Health Professionals, formerly known as the Health Occupation Students of America, for all their travel. So all the students rural travel. And then we're also going to be providing an academic tutor on each island for group and individual sessions. This will be to support that health certificate training program and anything else the students need. These tutors will be on each island, so they will have a contact there. I'm now going to turn it over to Claudine. That's going to talk about the healthcare future and the current learners that we're going to have.
Good morning, everyone. So for the future and current learners in healthcare, Home Run plans to offer education awards to cover tuition for everyone who commits to working in rural areas for 5 years. This includes tuition for both online and in-person training for all direct healthcare and IT personnel. Further support will also include travel for training in rural Hawaii for all local students and residents in medicine, nursing, physician assistant programs, speech language pathology, social work, and other health professions training programs. To continue talking about this, I have Dr. Buenconsejo.
Hi, everyone. So as Claudine mentioned, and I have come to you all many times before, we know that it's really important for our learners to train on the neighbor islands and in rural areas. And so what was mentioned earlier is for the pre-health, right? And the travel funds are going to help with the folks who are actually in health professions programs in schools. But what's very exciting is this gives us the opportunity to really plan and hopefully get some of our rural training tracks. You've heard me speak before about graduate medical education and residency programs, and if JABSOM aims to increase the class size, if we don't have residency slots, then that's hard, right? So this money is going to be very, very useful, and we are already planning for nurse residency training programs. So again, that's kind of a transition from nursing school to practice in the neighbor islands, but also working hard with many of our neighbor island hospitals already, looking at potential rural tracks or programs in primary care internal medicine and maybe pediatrics, obstetrics, surgery, psychiatry, and family medicine. So the other thing that is important with this workforce development is actually our current healthcare workers. We know that there's a lot of capacity building to be done. Your committees here have spoken many times about how we want to change the healthcare delivery system so that more people can receive the care at home, right? That's appropriate for them to receive at home, and then really only need to transfer if they really have to, right? So that's kind of that long-term goal. And so one of the initiatives here is actually dealing with newborn care. Sometimes we have a lot of high-risk pregnancies in the state. Sometimes babies are delivered early. And it's really important that all of the pediatric providers or the family medicine docs who deliver babies, that they are able to care for those earlier, sicker newborns and keep them well and stable, and then determine if they need to be transferred. So that's an exciting program. It also includes monitoring after discharge from the neonatal intensive care unit and other things. And for the most exciting part, I'll turn it back to Claudine.
So another component of home run for current active and healthcare workers is provider incentive payments of up to $200,000. These will be one-time payouts to healthcare workers who will commit to work in rural Hawaii, in the rural areas of Hawaii for 5 years. There will be support for health workforce conferences, community meetings, and mini grants for health improvement activities. Statewide, there will be coordinated healthcare provider-focused well-being initiatives, as well as the creation of a wellness calendar and activities to support retention. Unless my colleagues have anything else to add.
Thank you very much. We'll be here at the end for questions. Mahalo.
Now we can bring on Dr. Jack Lewin, if you'd be willing to talk about two initiatives, the Rural Health Information Network and the Rural Value-Based Innovation and Ahead Readiness Fund.
Thank you, Ian. Aloha, chairs, vice chairs, and members. Jack Lewin here, Administrator of SHPTA. We are honored and excited to be overseeing the implementation of two of the hubs. One is the Rural Health Information Networks, and the other is the Rural Value-Based Initiative. Let me start with the Rural Health Information Network. This is over $45 million a year to work in several categories to improve healthcare services in general across the state. I might point out that it's important to note that this is a partnership with MedQuest Division on these activities, and with DOH and with others to succeed. First, we're going to put electronic health records out to those that don't have them, and we'll be able to upgrade electronic health records for those who have them but really aren't fully functional. That's a big chunk of the resources and a big opportunity for us to be a state that has a total interoperability connection across all of our rural areas and our urban areas together. That's a big challenge, but it's one that we think we can manage, and we can get the money out pretty quickly and directly in very useful ways. But in addition to getting the electronic health records out, we need to create interfaces with those records and the other end users. And we need to train the people in the institutions and the offices, hospitals, and other facilities to be able to use these effectively. So that's all part of this program. We're going to build another hub statewide, which will coordinate quality of care. And it will involve turbocharging our health information exchange to be able to do that effectively. And that's an exciting project for us as well. Working with MedQuest Division, we're going to have another hub that works on bringing social determinants, health-related social needs together with our clients and patients in a much more efficient, effective way. We have a specific proposal for our dual eligible Medicare, Medicaid beneficiaries who are, in essence, the folks who need health resources and spend health resources in the most significant way. We're going to coordinate those services better. We can do a whole lot better with that whole population of people with their special health needs. And we have another project that is going to try to bring together with data analytics the two major sources of data that we're using to understand how we're doing in healthcare. One of those is the all-payer claims database, which is going to become functional as of this year in stages. It doesn't include yet the data for Medicare Advantage patients, and it will be lacking 250,000 commercial lives, but we'll bring those in over the next few years to the all-payer claims database. That is not being funded by rural health, but it's a tool we'll use to connect to the clinical data in the health information exchange to kind of make more comprehensive observations about health and healthcare improvement. So that's kind of a general summary of the Rural Health Information Network projects. The Rural Value-Based Initiative is important to note because it's an expression from CMS directly that the AHEAD grant model is something they value. Because this particular bucket is going to prepare hospitals, health centers, and community providers to prepare for alternative payment models and the challenges of the AHEAD model. And that is going to be $25 million a year, and we'll be bringing direct services in facilities and across that spectrum to help them prepare, but also to really take advantage of funding opportunities we're not taking advantage of now. Medicare, for example, offers the MSSP programs where people can actually get paid for value-based improvements. Today, we're not really availing ourselves of that opportunity very greatly across the state. So some of these things are going to really enhance the income stream of providers over time. So those are in essence, those are the two things. We can get into detail if you have questions, but it's SHPTA, MedQuest, and DOH together on these projects. Certainly the value-based preparation for AHEAD is really a true partnership between MedQuest and SHPTA. Thank you.
Now if Dr. Christina Higa would be able to talk about our telehealth initiative.
Good morning, chairs and vice chairs and committee members. Aloha, I'm Christina Higa. I direct the Pacific Basin Telehealth Resource Center at the University of Hawaii. It's one of 14 federally funded resource centers in the country, and our center serves the state of Hawaii as well as the U.S. affiliated Pacific Islands. Our center has been working on trying to advance telehealth for the last 16 years and have seen a lot of changes, especially as you all know in the pandemic. We have had so much more adoption of telehealth from patients as well as providers. And so I think this initiative, the telehealth initiative of this Rural Healthcare Transformation Program, comes at a really great time. Pili'ola is the name of our initiative, and we're going to keep momentum going with advancements of telehealth. So the telehealth initiative's goal is really to expand and strengthen telehealth initiatives in the state of Hawaii, and in particular for the rural areas. As Lauren had mentioned in the beginning, some of the programs did look for projects that could scale up existing programs, and ours is one of them. We're one of the smaller initiatives. If you look at the budget, less than half of the most of them, but we really saw the past experience of some of these programs taking years to get to the point where they are now. So this fund is really going to help to expand them to rural areas, especially so they can get the care services they need. But a big part of our focus is really to match the rural healthcare needs with their telehealth and their healthcare needs. And we want to stay aligned with the rural reality, you know, to understand what works and what doesn't work. Because in telehealth, we have seen many things in the past that did not work, and many things that have. So a big part of our work will be coordination, understanding and listening to rural communities and their needs. And so we're building a stakeholder engagement framework. So there'll be a coordinating council and working groups that take agendas from the council and staff to move the agenda. Policy, technology, training, clinical applications, for example. As I mentioned, many of the programs that were proposed have a track record, and those will be scaled up. Another big component of the telehealth initiative is the workforce and training, especially in the area of supporting your community members in getting access to telehealth and helping the patients. So we will provide that so they have the best experience. So if I could just move quickly to highlight some of the programs. There are many different types. These fall under expanding access to care for where the patients are. So we have a telehealth access point and navigator project. Again, this was, we had a very successful project in partnership with the Department of Health in libraries and telehealth. That was a CMS project that unfortunately was defunded, and we had to close it down and let go of all the navigators, but it was very successful. So this funding will enable us to reestablish it, but we made some changes through lessons learned, and we would use libraries, which was great. But when we did the project, we also found community centers, churches, homeless shelters, many other places in the communities that wanted to have these services, actually brought people to our navigators. So we'll expand on that. We have another one that's telehealth in the workplace, working with employers to make sure they understand the benefits of telehealth for their employees. This started with an idea with the Hawaii Island and the hotels on the west side where people take 3 hours to bus in to work. And we had a health fair, and we found so many people with high blood pressure that was unknown or untreated. So the idea was to work with employers to get a space. These people have no time in their day, and they can, you know, find telehealth and help them with employment wellness programs. And of course, we added state employees, government employees, because the biggest employer. There'll be kiosks in the communities, virtual chronic disease monitoring from home, school-based clinic, telehealth services expanding to Molokai and Hawaii Island, to charter schools where they're currently not located. And then moving on to the safety net services, maternal telehealth programs, expanding that. That program took a long time to get where it's at, and now it's the stage 2 scale. Telehealth, mental health, behavioral mental health, infectious disease, and e-consulting, where primary care providers will be able to get specialty consultation. So in closing, I just wanted to say again, in comparison to the other initiatives, you know, our funding is, you know, less than half, but if you listen to the other initiatives, many of them have telehealth as components to it. And so we will work across the initiatives and coordinate and help to have them plugged into our stakeholder engagement frameworks in the same way as us plugging into theirs, because I think they're all connected. All the initiatives are really connected to really truly transform healthcare. And I think telehealth has a major role in that. So that will be our commitment to this program. Thank you.
Thanks, Christina. Director Fink, if you would be able to talk about which is Rural Infrastructure for Care Access Initiative.
Aloha, I'm Kenneth Fink with the Department of Health. The initiative that was named the Rural Infrastructure for Care Access, or RICA, is the initiative for which the Department of Health will have the lead. As you've heard from these other initiatives, there really is a focus to increase access to care in rural areas, you know, where rural residents reside, and we incorporate that too. One of our priority areas in this initiative is should they need to go somewhere else for their care. In light of recent tragic events, some work with our federal partners, and the National Medical Disaster System, one of our 4 priorities under this initiative is really strengthening the EMS and trauma system statewide with centralized patient transfer. So in the event that a large number of patients needed transport from medical care, we really feel the need to use this opportunity to invest in that statewide capability and system development. So one of the 4 key focus areas within this initiative is to build out a medical communication center, which would integrate kind of the hospital capacity system. We would use a technology called Pulsara, which allows for, again, more telehealth. In addition, with that infrastructure is to upgrade ambulances and provide Starlink capability so that particularly remote areas, care can begin on scene with perhaps consultation with a tertiary quaternary center as needed. So there's equipment investment in ambulances, Starlink, infrastructure support. Other priority areas for this include increasing the trauma capability on the neighbor islands. For a couple of hospitals, we look to invest in simulation equipment for training and to provide more training opportunities to be able to provide enhanced trauma care on site on those islands. And to support our level 1 trauma center to begin with telehealth neurotrauma support of those neighbor islands. So again, this is a key area to strengthen our EMS and trauma system statewide. As we build out our EMS system statewide on a county level basis, looking to build that out and leverage that through community paramedicine. So there are some areas where we have EMS capability that is not fully utilized based on the volume of responses that they have. So how do we leverage the resources that we have to do home checks? There may be people who are calling 911 repeatedly for non-emergent reasons. So how do we care for people in the most appropriate setting? And then expanding those EMS programs with other resources such as community health workers or nurses to support more outreach into the community to increase access to care and, again, check on folks. In addition to kind of that aspect within this theme of community paramedicine is also to invest in a mobile medical clinic. So having a medical van that would go around to expand access to care, again, on those neighbor islands. We've been intend to start on the Big Island for the community paramedicine because they have the most well-developed program. And as we invest and build that out, we'll get more lessons learned for how to spread that into the other counties. For the medical mobile clinic, we're looking to pilot that on Kauai and stand that up there. And for the trauma simulation equipment, we'll be investing in Maui and also in Hilo to get those started. Another one of our key focus areas is how do we expand the reach of primary care? So this is separate from the community paramedicine. This is kind of the next level. And wanting to leverage what primary care providers can do and how to support them. So keeping people healthy is really the ideal state. So we will be using this funding to increase activities in promoting nutrition and physical activity and healthy behaviors and continue to do that sorts of work. I just actually came this morning from an event recognizing the volunteers for Senior Medicare Patrol, the State Health Insurance Assistance Program, and it's the value of volunteers. So shout out to them and those volunteers. But there's a tremendous capacity of volunteers and really want to acknowledge, the gratitude for people who are giving back to their community. So there's a project that will be pursued to how to leverage volunteers to help support their neighbors and community members. So that's an important effort. UH College of Pharmacy has a program where they train pharmacists and community health workers to help with medication management and disease management and they can work with primary care practices, again, to expand that reach. So that's another focus area. With those community health workers, if we can expand the work of public health nurses, so using the CHWs as kind of expanders or force multipliers of our public health nurses, again, to get out more into the community, reaching people and servicing them. And then there's also a part of oral health. So within that oral health, there's kind of two components. One is working with the federally qualified health centers to do minor remodeling and add dental chairs to increase the number of people that they can serve through those FQHCs. And another aspect is to partner to increase access to oral health screenings and dental sealants through school-based programs. And then the last of our kind of the themes is behavioral health. So that's another focus area for us. We'll be investing in expanding crisis mobile outreach to include peer specialists. So people with lived experiences are a critical part of those teams to support those initial responses and support stabilization. We'll be investing in mobile behavioral health clinics. We know there's a need to increase access, and we need to reach people where they're at. So these mobile behavioral health clinics will help increase access to services. And it was already mentioned through that telehealth and another kind of linkage across initiatives, looking to create a hub to provide behavioral health consultation to primary care providers. This was kind of piloted, I think, with pediatricians on Maui, supporting their care of children who had mental health needs. So kind of learning from that and expanding that to provide more tele-mental health support, particularly supporting primary care providers to care for their patients, in those communities. So those are the four key areas. There's other aspects. There's some, evaluation components and strengthening our ability to assess how we're doing and assess what those needs are as we inform what we'll do in future years. Because this first year, I don't know if that's been raised yet, this budget period one, it was only 10 months, and all the future years will be kind of 12 months. But this 10 months kind of started in January. We're already in March and don't yet have final approval from CMS. So it's going to be a very short window for this first budget period. So we really focused on existing contracts or things we could do through memorandum of agreement, recognizing we need to obligate these funds because next year's funding will be based on our ability to expend kind of this year's funds, and that will occur each year. So that was one strong consideration, particularly for this first year, was how we could leverage kind of existing contracts and agreements that we already have. And like everyone else, we'll be available for questions.
And finally, Director Campos, if you'd be able to talk about the Rural Respite Network Initiative.
And Ian, thanks for the promotion, but Deputy Director.
We won't tell anyone.
Okay, good. Department of Human Services. So the initiative that the Department of Human Services is taking the lead on is the Rural Respite Network. It's going to be a network of 5 respite sites, 2 on Hawaii Island, 1 on Maui, 1 on Kauai, and then 1 in Waianae on Oahu. It's basically going to be designed to provide short-term residential care for individuals recovering from hospitalizations who lack stable housing or sufficient home supports. So this is designed to ensure that, one, the success of Pulamaola that we had, 2.5, 3 years ago, can continue. I think that was a good model that showed it is successful in helping to reduce hospitalization costs, as well as provide people the necessary places for them to recover in an appropriate manner. As Director Fink mentioned, right, we are in budget period 1, which is a shortened period of time, so we're looking at 2 respite sites, 1 on Hawaii Island and 1 on Kauai. And then the next fiscal year, we will be looking at expanding the additional 3 respite sites. And so basically that's a real quick version. We're already at 10:40, so I'll step aside and then you have to finish something or, and then we'll get questions. Thanks.
I just wanted to just give an overview of kind of how the funding operates. So we've had our first year award of 188.9 something. And we anticipate receiving, so that's the dollars for the first budget period, all to be expended by the end of next September. And then we anticipate receiving 4 additional awards, I believe each kind of November in subsequent years. And the specific, kind of size and amount of those awards is anticipated to be similar to our current one, but it'll depend on our compliance and our progress on our various initiatives. So we'll be providing an annual progress report to CMS. Each of these initiatives has at least 4 outcomes or targets that they are seeking to progress on, so we can demonstrate to CMS that not only are we putting these dollars to use, but we're getting outcomes and benefits from them. And so we're working very closely with CMS on kind of finalizing those plans, and we'll continue to work with them to make sure that we're delivering on these and that we get these federal dollars. Every single one of these dollars is coming from the federal government in subsequent years. And we're also currently in the progress of standing up this oversight team, which will ensure compliance and aid our initiative leads in executing their initiatives, and also ensuring that all of these initiatives cooperate and work together, because that'll really get kind of the transformational potential of this program just as great as possible. So that closes out our presentation. So now we can take questions for any of us here.
Great, thank you all of you for your presentations, and thank you for your very timely presentations. Before we'll open it up to questions, I'm sure we have tons of questions. Let me sneak in a real quick one. Define rural,
Yeah.
especially as it applies to Oahu.
Yeah. So our the definition of rural that our program uses is the one given to us by HRS. For the purpose of federal programs. So that's HRS section 1B1. And this, it's a definition used for determining the area's rural status for the purposes of a federal program that accepts state definitions. So it includes all neighbor islands, and it includes large parts of Oahu. I would have to, I can work on getting you kind of the map itself, but I believe it includes Waianae Coast, and then Wahiwan, what's north of it, and Ka'ava, and what's north of it, is the map is last time that I recall. But it is important to kind of understand the relevance and importance of what that definition means, because it serves primarily 2 purposes. One is it provides a geographic constraint on these 5-year workforce commitments, and so if you're going to receive an education award or provider incentive for committing to 5 years of rural service, CMS expects those years to be served in a rurally defined location. The other relevant component or function of this definition of rural is that it provides a reference point for our metrics and targets. So when we tell CMS that we're looking to get a certain number of certain percentage of our rural provider sites to be interoperable, they will be looking at those sites within that definition that we gave them from HRS. But CMS, they recognize that rural health is not only benefited by investments directly into rural communities, and they also recognize that rurality exists on a gradient, and so they don't have a strict restriction on expending these funds specifically in this defined rural area, with the exception of that 5-year workforce commitment, which they do expect to go to people serving.
Okay, Waianae Coast, Central Oahu, Wahiawa up Waimanalo?
Yeah, Waimanalo is included,
Okay,
as well as Ka'ava and.
okay, that answers Rep. Martin's question.
Yeah. Good time.
Okay, members, questions, let's start with House members.
I have another question. Hi, Ian.
Hi.
So we talk about telehealth, now we're kind of thinking about Zooms and stuff, but when telehealth started, before we had the, advent of Zoom, it was really much more high tech, and you could have a lot of tools to do different, on the ground examinations that could then be shared very high definition with people on the other end. And I'm wondering, when we're talking about telehealth, are we looking at that model of more sophisticated applications that people can really be remotely doing real examinations inside the body, et cetera?
Yeah, that's a really good question, because the technology itself has changed a lot. There's still certain applications, for example, the maternal telehealth application is a combination where they'll do the teleultrasound, but the pregnant woman would have to go into a healthcare facility, and then the connection will allow the scan so that maternal fetal medicine specialist can view it from Honolulu. But there's also other aspects of it where you might have fetal monitoring instead of having to drive in and wait for your session, and drive back home. They can do it from home. So there's some of those applications. A lot of people have asked me about primary care. Is that appropriate to use telehealth, or if you need to listen to breathing, heart rate, etc. And the grant does have very commonly used technologies now that's available for home, and also has really good support so that the patient or a remote nurse or someone who's using it can get directions from the remote provider. So yeah, the technology is really increasing. The program itself will use a combination of all of those.
Okay, thank you. Thank you, Chair.
I do have a question.
Hartsfield followed by Lewin.
It's a budget related question, so I'm
Sure.
assuming you're the person. Okay. So this 5-year program, the annual awards are going to be dependent on federal approval and performance. So my question is, how often will CMS review progress and compliance?
Yeah, thanks for that question. In this first year, our first official report to them will be our annual progress report submitted at the end of August. We meet with our project officers bi-weekly at this point and update them on our progress. And as they kind of develop these templates that we'll be using for these progress reports. But our first annual progress report will be due August 30th to describe the activities, I think up through July. And then subsequently, every single year, we'll have another annual progress report due at the end of August. But in the months in between, we'll have quarterly reports beginning after this first annual progress report. So there'll be kind of very close oversight and working with CMS.
Thank you. Chair, I have 2 more questions, but I'll have.
Okay.
Yeah.
For all members, if you come up with more questions, write them down and I'll make sure and pass them on. So, okay, go ahead, Vice Chair.
Yeah, thank you. Thank you for the good work. I'm just really curious, like my colleague, we have this incredible spend down and we'll have a number of assets. The question is then what, right? And I know Lauren talked about there's going to be some planning for that. When can we engage in that process? And then as far as the repair, maintenance, and upkeep of some of these assets, which are absolutely needed on the Big Island, how do we transfer that and or get those community readies to maintain them after these assets are deployed?
Yeah, thank you for that question. I think that's a great question. I think that's also one that I think every state is considering how they're going to make this truly transformational and how they're going to put these federal dollars to use and not just kind of make investments that will just fall off after 5 years, because unlike the cuts that came out of HR 1, this is short term. This is 5 years only. I think we'll be each initiative lead as well as the oversight team that we're building out. We'll be working on that, considering how we can ensure that these programs are sustainable. That was one piece of our project narrative. The final piece was a sustainability narrative. And so, we outlined kind of the overview and our hopes for the projects, but I think it'll be a task of this oversight team and of each of our initiative leads to ensure that we're making these changes and making them transformational, and also not, leaving anyone on the hook for, subscriptions and maintenance that will be too much to handle.
Let it go, but yeah, when you guys get there, like,
Yeah.
reach back out.
Yeah. Definitely, 100%.
I just wanted to
And then I'll
add one real
Yeah.
comment. As Dr. Higa mentioned, there will need to be a lot of listening
Yep.
to rural community health needs. And so we're going to begin to think through some of what that looks like and to stand that up. But, this just can't be people in Honolulu figuring everything out. So rest assured that there will be a lot of listening and community engagement.
Okay, Model, and then I'll turn it over to Senate.
Thank you.
Thank you, Chair. So I'm not really sure who to direct my question to. But basically I'm curious about an AI component. We've heard about telehealth and many different programs. Is there an AI component to this money? And if so, how is that going to be utilized in supporting physicians, bringing them up to speed with technology and going forward for their patients?
I'm not, Christina?
Thank you. Another really important question with the development of technology, and we do in our telehealth initiative budget, we have a small AI lab kind of work. It's not defined yet because when the proposals came in, there was so much not agreement, on what should be focused on. So part of what the telehealth initiative would do through our stakeholder engagement framework is to identify this platform. There is one for the FQHCs. There's an FQHC has been doing a lot of use of AI, especially for analyzing social determinants of health and interventions and all of that. They will continue that, and we will see if that's a model that can be scaled to other FQHCs. On our other TRC side, Telehealth Resource Center side, we're doing programs on AI and safety just for people to get aware now on what you should look out for, especially in healthcare and AI. So we'll continue to put that into the initiative.
Thank you, Chair.
There could be, let me add just one component. As we get into the rural value-based initiative, physicians, practices, clinics, community health centers will have an opportunity to use AI tools as part of what they need to empower them to participate in the new models in the future. So I think we certainly will involve those there as the practices want to adopt them. Thank you.
Okay, thank you. Senate, do you have any questions? I do.
No, you go first, and if there's any time, I'll jump in, but you first, go ahead.
Lauren, come on up. So I'm a bit disappointed. The whole idea behind the Rural Health Transformation Program is to help rural communities weather the effects of OBBA, which means 6% to 7% of the population is going to be uninsured. I didn't hear anything about how we're going to help the uninsured.
That's a very legitimate question, and it goes back to some of my opening comments about, loss of federal funding for Medicaid down the line. We'll certainly take that back into consideration.
$188 million to be spent in 1 year. What are you guys gonna do to help out the uninsured? I mean, are these telehealth gonna be directly for the public who are uninsured? Are they gonna be able to pick up a phone and ask for medical consultations? I didn't hear that.
So
Okay, I heard the medical rest, but I heard the telehealth being expanded and maybe AI and it's a lot of shock and awe. But nothing for the regular people who are uninsured that are gonna be facing, they're gonna be losing medical care this year.
correct.
What are we gonna do to help them?
Well, certainly in conjunction with some of the safety net programs, we'll be coordinating responses. So many of the interventions that have been proposed at a high level here are not just based on a fee for service or reimbursement, a healthcare financial transaction. It is entirely conceivable that respite or telehealth or community outreach and community paramedicine will be able to accommodate and should be able to accommodate those without insurance. So reimbursement from a third-party payer should not be a barrier to certain uninsured individuals receiving the benefit of this program.
That doesn't really answer the question, okay? You haven't actually answered.
how an uninsured, because we're looking at an unprecedented amount of uninsured because of the ACA premium credits expiring, as well as the Medicaid and disenrollment requirements. How are they gonna be able to hit to go get medical care? Can they just pick up a phone and ask for consultation? I didn't hear anything like that. Can they just go to a doctor with a voucher and say, hey, the Rural Health Transformation Program is gonna ensure that I'm gonna be able to get medical care with this voucher? I didn't hear anything like that.
So, correct. So, I'm gonna, I guess, restate something I said earlier, is that, the thinking behind this wasn't how do we maximize insurance reimbursement? It's how do we fill gaps in the community?
I didn't say medical
No,
reimbursement.
understood. And so that's getting at persons who are uninsured. So this wasn't built with, okay, how do we just make insurance pay for this or that? This is truly needs-based. And so the listening that we're going to have to do will elevate and prioritize some of those issues. But again, it is entirely conceivable that many of the projects that our colleagues have presented will be available to those who are truly
But that was
uninsured.
the very purpose of the Rural Health Transformation Program was to alleviate the effects of OBBA and not to create new stuff.
Well, I'm actually, I think that might not be fully the case. They did include within the Rural Health Transformation Program a specific cap on provider payments, which are things for the services for the uninsured. And they put that cap at 15% because they did not want this funding to just go towards, undoing for, a short period of time what they did in the same bill. So they specifically created this program, right? It came out of the same bill to do things, different than, what they had done before. And they put on us this specific constraint, 15%. So nowhere near the 189 million for the first year. If we go over that, that would be violating, our agreement with CMS and so we are capped. The program itself caps us at what we can do, the specific amount of dollars that we can give for services for the uninsured.
So, but where's the 15% then? What did you do with the 15%?
Well,
I didn't hear anything.
Well, it's spread across the various initiatives. We don't have a specific initiative that is just going towards, this initiative, the very specific initiative. Its purpose is just to serve the uninsured. Instead, we're trying to build systems and include within that components in each of these initiatives to serve the uninsured.
Chairman,
Go ahead.
we gotta get out of here, so
Yeah,
real
we gotta get
quickly,
out of here.
these will be answered via letter. I counted 4 Washington DC lobbyists on these groups that are supposed to guide this. Why are they there? What are they doing there? And who's paying them for their time? Number 2 is I could look at this and I see a lot of places where you could argue that you're supplanting funds. How are the bright lines going to be established to ensure that that argument is thrown? Here's the bottom line. You got administration. In previous administrations, you could count on certainties through CMS. There's a lot of uncertainties. Going forward, this future money may not show up. There may be restrictions. CMS may demand what's being spent on immigrants. Okay, so we're investing a lot of resources, to Representative from the Big Island's point, in these communities without a guarantee that there's going to be continued funding to support their continual operation, R&M, and everything else, which could all fall back to us. And to Chair's point, we're facing an insurance nightmare of people losing coverage. And when they don't have coverage, they need to know where they can go and get that coverage. So that 15% should be front and center to the whole plan. So anyway, letters in writing, and finally the RFP process for the equipment. I've heard that it sounds like our decisions have been made on what they're going to acquire. When was the RFP process engaged in? We have an RFP process. So if you guys can get back to me with a letter on that, I would greatly appreciate it. Appreciate you guys' times. Thank you for continuing work on this, and mahalo.
Yeah, we gotta go.
Thank you. Before we leave, thank you, senators. Just want to ask members, if you do have questions, forward them to me, and I'll be the collecting point.
Yes.
And make sure
And I'll do it for the Senate.
make sure that we distribute. Well, I'll send them to Lauren and you and you folks. I'll distribute the responses. Okay.
Thank you so much.
Thank
Okay,
you.
thank you very much.
Thank you for the job.
We're adjourned. Thank you so much.